think it's already 10 past, or nearly 10 past. We can start the session, otherwise it's going to be too late. Good morning, everybody. We hope you have you had a very nice evening, nice dinner, some rest, not like us, and you enjoy the Saturday morning sessions. The first session is going to be around myocardial revascularization, what's new, what happened in the recent time, and we have two very well-known speakers here. And the first one is Stefan Windecker. Stefan is one of the leading interventional cardiologists in Europe. He's working in Bern. He's professor of cardiology there, and is probably one of the persons who has been more directly involved in the in getting the new guidelines, and I'm sure he's going to tell us what's the new things from last night in the guidelines. Thank you very much, Stefan.
So, good morning, dear colleagues and friends. Thank you very much for the kind invitation to contribute to this meeting. And it will be my task to touch upon some recent trials comparing PCI and coronary artery bypass surgery. Now, before doing so, I'd like to have some introductory remarks. And obviously, coronary atherosclerosis remains one of the leading problems in terms of morbidity and mortality, as recently summarized by Peter Libby here in the New England Journal. And really, we are faced by two kinds of problems resulting from coronary atherosclerosis, one being acute coronary syndromes, which manifest as ST elevation or non-ST elevation myocardial infarction, and the other stable coronary artery disease. I think it's also important to realize that in view of the aging of the population, cardiovascular mortality due to coronary atherosclerosis remains quite important, with major increase obviously expected in the octogenarians. Now, the advances of cardiovascular medicine have been summarized 2 years ago on occasion of the 200th anniversary of the New England Journal of Medicine by Elizabeth Nabel and Jean Broadwald. And as it relates to revascularization, you will see that there are important contributions to the field for both coronary artery bypass surgery, here as highlighted by the event from Favaloro, and then in 1977 the introduction of PCI by Andreas Grünzig. And I think it's also important to realize that today, 2014, is the 50th anniversary of coronary artery bypass surgery. So really in 1964 the procedure was probably performed for the first time in Russia by Vasily Kolesov, and at the same time in the United States by Michael DeBakey, although Michael DeBakey only wrote it up in 1973. And really the father of cardiovascular surgery in terms of coronary artery bypass surgery has been René Favaloro, who systematically worked up the scientific evidence. Also interesting to see the early operative results published in 1975 in the New England Journal were not so favorable. If you look at the mortality rate of 10% and the myocardial infarction rate of 15%, then this is more comparable to our experience currently in transcatheter aortic valve implantation. But obviously there has been major progress over the past 5 decades, which have been recently summarized by Stuart Head in an article in the European Heart Journal. And really, this meta-analysis by Selim Yusuf comparing coronary artery bypass surgery with medical treatment established the superiority of coronary artery bypass surgery, particularly in advanced coronary artery disease, 3-vessel coronary artery disease, and left main disease. About 13 years later, in 1977, then we had the advent of percutaneous coronary intervention. Here the patient, here his physician, they actually were age mates. They were both 38 years old. The patient is still alive. Unfortunately, Andreas Grünzig, he died during an airplane crash. And this was the surgeon, Marco Torina, who provided the surgical backup during this very first procedure. And as you are all aware, obviously in the meantime there has been major progress in the field of percutaneous coronary intervention, namely the addition of drug-eluting stents, which are really high-tech devices consisting not just of a stent platform, but also being composed of now new generation polymers, which are quite biocompatible and mainly limus analogs, which suppress neointimal hyperplasia. And last word of introduction is just to introduce you to the wealth of evidence which has been generated over the past 5 decades with a large number of randomized clinical trials comparing coronary artery bypass surgery with medical treatment with various techniques of percutaneous coronary intervention. That in total of more than 100,000 patients have been actually studied with these various revascularization techniques, and certainly certified to the fact that this intervention, be it coronary artery bypass surgery or PCI, is one of the best studied medical interventions in the entire field of medicine. Now, before I come to the comparisons between PCI and coronary artery bypass surgery, I'd like to talk a little bit about the progress with drug-eluting stents over the past decade. And here on this slide, you see schematically a summary of the early devices we have used 10 years ago and current devices. And you immediately note that in terms of strut thickness, these devices we use in nowadays only have 1/3 of the strut thickness as compared to these early devices. In addition, the polymers we are using are applied at much lower thickness, only 3 to 4 microns as compared to more than 12, 14 microns with the early generation drug-eluting stents, and they are much more biocompatible both for durable polymers but also by the recent addition of biodegradable polymers. And in the early phase, we had both the sirolimus and paclitaxel, and you see with the more recent stents, it's basically only limus analogs which are utilized. Now, it has been recognized that the bare metal stents, their main limitation was the excessive amount of neointimal hyperplasia. And really early generation drug-eluting stents took care of that problem, but unfortunately in 1 to 2% of patients they were associated with delayed arterial healing and some idiosyncratic response which led to these evaginations. It was only the advent of new generation drug-eluting stents which not only suppressed the neointimal hyperplasia as effectively as the early generation drug-eluting stent, but also was associated with more homogeneous kind of bleeding. Now, has this translated into improved clinical outcomes? I do think so, and here I just show you one piece of evidence which is a pooled analysis now applied solely to female patients, but which shows you now in terms of efficacy, target lesion revascularization, the event rates for bare metal stents, early generation drug-eluting stents, and new generation drug-eluting stents. And I think it's unsurprising that obviously drug-eluting stents are much more effective as compared to bare metal stents. But what you also note on this graph is that the new generation drug-eluting stents are even more effective than the early generation drug-eluting stents. The differential is not large, but I think it's important to realize that if anything, they are at least as effective and likely more effective than the early generation drug-eluting stent. One important limitation of the early generation drug-eluting stent has been the problem of stent thrombosis, and particularly one idiosyncratic reaction during the very late phase, more than 1 year after implantation, the issue of very late stent thrombosis. And here again, you see the event rates for early generation drug-eluting stents, and here you see the event rates for both bare metal stents and new generation drug-eluting stents. And I think you immediately note that the event rates for new generation drug-eluting stents are as good as for bare metal stents, that there is numerically no relevant difference between bare metal stents and new generation drug-eluting stents. And somewhat provocative, also unproven, is that probably this benefit, both in terms of safety and efficacy, translates into an improved outcome for overall ischemic events. Here you see the composite of death and myocardial infarction. On top, the bare metal stents, here the the early generation drug-eluting stents and here the new generation drug-eluting stents. And there is more evidence forthcoming from meta-analyses indicating that at least with one stent type, indeed there is a mortality benefit as compared to bare metal stents. Now I'd like to show you some more recent evidence of PCI versus medical treatment. One study has been the FAME2 study looking at the outcome in patients with advanced coronary artery disease, and one important adjunct in diagnosing the coronary artery disease was that all lesions were ischemic as determined by an FFR of less than 0.8, and patients were then randomly assigned to PCI with medical treatment or medical treatment alone. Now here you see the outcome for the primary endpoint, which was a composite of death, myocardial infarction, and urgent revascularization. And you see here in this open label study a huge differential in terms of the primary outcome between medical treatment and a PCI and a medical treatment. Of interest is also to see that the event rates in the PCI medical treatment arm were quite comparable to the registry arm of patients with an FFR of more than 0.8, who were just managed medically. Now, the important limitation of this study was obviously that the entire difference was driven by the endpoint of urgent revascularization, and that we have only limited information about ischemic endpoints like death and myocardial infarction. However, one important point is that this was urgent revascularization. It was not just elective revascularization, but it was urgent revascularization defined as revascularization in the setting of an acute coronary syndrome or unstable angina. And you see that at least in 50% of patients, indeed, there was objective evidence of ongoing myocardial infarction or at least electrocardiographic evidence of significant ST T-wave changes. And one other important consideration is due to the controversy of periprocedural MI versus spontaneous MI, and landmark analysis looking just at the event rates for death or myocardial infarction beyond the periprocedural period. And here at least you gain the impression that potentially an invasive treatment may be more advantageous as compared to medical treatment. Now, this has been recently corroborated in a meta-analysis published by Shripal Bangalore, and he looked specifically at the incidence of spontaneous myocardial infarction in trials comparing PCI versus medical treatment. And what he observed in this meta-analysis, that indeed, if you ignore periprocedural MI and just focus on spontaneous myocardial infarction, that there is a benefit during long-term follow-up in favor of percutaneous coronary intervention with a non-significant trend for mortality. So all of this is not proven, but at least it gives you a flavor that if anything, PCI is at least as good, and that there may be signs that actually in terms of spontaneous MI, there may be a difference in favor, and that these results may become better with the application of new generation drug-eluting stents. Now, if we come to the more advanced coronary artery disease, discussing now PCI versus coronary artery bypass surgery, we obviously know the advantages of the respective strategies. PCI is less invasive, you require shorter hospitalization, there's a lower risk of stroke, and improved immediate quality of life. Conversely, coronary artery bypass surgery affords more complete revascularization. There are fewer repeat revascularization events during long-term follow-up, and there is also the emerging thought that it is more protective against future ischemic events. Now, the first slide I want to show is actually a comparative effectiveness outcome from a large-scale registry in nearly 200,000 patients. And here you see an adjusted outcome in patients with multi-vessel 2 and 3 vessel disease comparing coronary artery bypass surgery with percutaneous coronary intervention. And in this registry, it's clear-cut that coronary artery bypass surgery is superior to percutaneous coronary intervention. Now, one caveat I want to outline is actually in the flow chart. If you see from how many patients this study population was drawn, then you see that there were 2 million patients at the very beginning to result in a study population of 200,000 patients. And what I like to express with this is, yes, these patients fare better with coronary artery bypass surgery, but really in 90% of patients, we do know what we need to do. That is, in the majority of patients with very advanced coronary artery advanced disease, we refer those patients to coronary artery bypass surgery. In less severe disease, we do percutaneous coronary interventions, and basically it's only in about 10% of the population where one or the other technique need to be discussed. Now, recently, last year at the ESC, the 5-year final outcome of the Syntax trial was presented, and it confirmed the superiority of coronary artery bypass surgery over a percutaneous coronary intervention, here for the primary endpoint of death, myocardial infarction, stroke, and repeat revascularization. So clear-cut coronary artery bypass surgery is superior to percutaneous coronary intervention. However, of interest is obviously the risk stratification according to the severity of disease, according to the Syntax score. Here you see the results for the primary endpoint, the composite endpoint. Perhaps more important is here the ischemic outcome for death and myocardial infarction. And I think everybody concurs that in patients with low complexity 3-vessel disease, there is no difference, not only for the composite endpoint, including repeat revascularization, but also importantly for death and myocardial infarction. Conversely, if we look at the mid-risk group with an intermediate score of 23 to 32, we see the absence of a difference for mortality, but there is a highly significant difference in terms of myocardial infarction. So clearly, this group not only fares better in terms of repeat revascularization, but also for an ischemic endpoint, myocardial infarction. And finally, if we look at the high-risk group, we have both a high difference in myocardial infarction and mortality, clearly indicating that in these two groups, coronary artery bypass surgery, without doubt, should be favored over percutaneous coronary intervention. Now, moving to patients with multi-vessel disease and in addition diabetes, there has been a very interesting meta-analysis using individual patient data published in 2009 in the Lancet. And the interesting aspect here was that actually the difference in terms of mortality was apparent in the diabetic population, but not in the non-diabetic population. And more recently, we have had the advent of the Freedom trial, which prospectively randomized PCI versus coronary artery bypass surgery now exclusively in diabetic patients. Please note that these were really patients with advanced coronary artery disease. They had a median Syntax score of 26. And in this trial for the composite now of death, MI, and stroke, so all ischemic events, clearly coronary artery bypass surgery was superior to percutaneous coronary intervention during long-term follow-up. I think the results are pretty clear-cut, but nevertheless, I like to draw your attention to 2 points. First, there have been absolutely no differences in the outcome up to 2 years. And then there's another interesting observation, and this is the differential loss to follow-up. Here you see the flow chart for patients under randomly allocated to coronary artery bypass surgery and here to percutaneous coronary intervention. Now, during long-term follow-up to 5 years, 92 patients got lost to follow-up in the bypass surgery arm and 32 in the PCI arm. And this is a phenomenon which is quite well established. It was already apparent in ARTS. It was also apparent in the Syntax trial. And again, it was apparent in the Freedom study. And if we come back now to the endpoint of mortality, we see here this absolute difference, which is also significant, 118 events versus 86 events. But if you would now take into consideration the differential loss of follow-up, and you would assume that all non-evaluable patients would have died, then you suddenly see that there is no longer a difference. Now, I personally don't think that this is the case because there has been another meta-analysis published in Lancet Diabetes. And here again, now with the incorporation of freedom, you see the outcome in non-diabetic and in diabetic patients in terms of mortality. And I think there's pretty robust evidence to indicate that clearly coronary artery bypass surgery in patients with multivessel disease is superior to PCI in terms of mortality, and therefore should be the treatment of choice. Now, nevertheless, there is the discussion whether the complexity of coronary artery disease, as indicated by the syntax score, has an impact on outcome. And there are two pieces of information, one coming from the syntax trial, where actually diabetes was not found to importantly affect the outcome as it relates to the syntax score tertiles. Conversely, in the freedom trial, it was suggested that the syntax score has no impact on the overall outcomes. But there's one important caveat, and that is that the freedom trial was actually designed prior to the publication of the syntax score methodology, and nowhere in the manuscript of the syntax score it's actually mentioned how the syntax score was ascertained in freedom. Now, having said this, I just want to present you the outcomes according to syntax score tertiles in freedom, here for low complexity, medium complexity, and high complexity. Again, I think there's no question for the intermediate and high complexity, but just looking at the event curves of patients with intermediate, with low complexity, even if the event rates are numerically quite different, I would say that probably in low complexity syntax score patients, even in diabetic patients, PCI may still play a role. And this also has been corroborated in a recent meta-analysis, now just looking exclusively at diabetic patients, incorporating the most recent trials, Freedom, Syntax, Cardia, and VA cards, and stratifying according to syntax score complexity, and you see that the outcome is worse, particularly for the patients with a high syntax complexity. Now, I also like to touch upon one limitation of coronary artery bypass surgery, which is the increased risk of stroke. Here you see the event rates for stroke in the Freedom trial, and here you see a significant difference in disfavor of coronary artery bypass surgery as compared to PCI. And this is also a pretty consistent finding, as you can see here in meta-analysis published by Tullio Palmerini in JAG, where clearly coronary artery bypass surgery, both early as well as late, is associated with an increased risk of cerebrovascular accidents. Now, how can we integrate this increased risk into clinical decision making? I think overall in most patients, stroke does not play an important role. However, there's an interesting publication of the adverse cerebral outcomes of coronary artery bypass surgery in the New England Journal, where they looked at the incidence of these adverse events according to age groups. And I think there is absolutely no concern in younger individuals here up to the 7th decade, but you see increased event rates among patients who are 70 years and older, and particularly in octogenarians. And one way to interpret these data is maybe that in very elderly patients, notably octogenarians, we have to take the risk of stroke into more serious consideration. And finally, as it relates to diabetic patients, I also would highlight that sometimes there are anatomical conditions, as seen here, with extensive diffuse multivessel disease, where neither percutaneous coronary intervention nor coronary artery disease are good options to provide an effective revascularization strategy in these patients. Now, I'd like to come to one more important topic, which is left main disease. And I think it came as a surprise in the outcome analysis of the syntax trial that actually in patients with left main disease, irrespective whether they were low risk or intermediate risk, the outcome of PCI was quite favorable as compared to coronary artery bypass surgery. So again, in low risk patients, absolutely no difference between PCI and coronary artery bypass surgery. Now in the subset of patients with left main disease, but a large differential in favor of coronary artery bypass surgery in patients with left main disease and complex coronary artery disease. And again, these findings as they relate to left main disease have been been confirmed in meta-analysis by Davide Capodano, where we see here the endpoint death and myocardial infarction for various trials comparing PCI and CABG in the setting of left main disease with absolutely no difference for death or myocardial infarction. And if we look again at the endpoint of stroke, there's even an advantage for percutaneous coronary intervention. And if you look at the repeat revascularization and disadvantage for percutaneous coronary intervention. So clearly evidence that PCI plays a role in the subset of patients with left main disease, particularly if they are lower complexity, so just isolated left main disease or associated with some mild remaining coronary artery disease. I'd like to conclude with some review we have done within our guideline group in looking at the entire evidence of a revascularization versus a medical therapy. So looking at any kind of revascularization methodology, be it coronary artery bypass surgery or various types of percutaneous coronary interventions. And here you see the results, and it's interesting to note if we just look at mortality, and here on the left side the revascularization therapy and here on the right side the medical therapy, then there is no question, and it is well established since the meta-analysis from Selim Yusuf, that coronary artery bypass surgery affords a mortality benefit. Conversely, if we look at the PCI strategies, we have to recognize that for the early PCI techniques, as well as the early generation drug-eluting stents, there was no evidence to indicate that there is any difference in terms of mortality as compared to medical therapy. However, there may be that with new generation drug-eluting stents, there is some progress in this direction, which certainly needs some more confirmation, and there are ongoing studies like the Isquémica trial. Here you see the same analysis for the composite of mortality and myocardial infarction with very similar findings. Again, robust evidence to indicate that coronary artery bypass surgery is superior to medical therapy. And finally, if you look at efficacy in terms of repeat revascularization, you see here coronary artery bypass surgery as compared to medical treatment, a huge treatment benefit. And here you see the progress over time from balloon angioplasty over bare metal stents to drug-eluting stents. It is easy to recognize that the drug-eluting stents afford a much better treatment effect as compared to both bare metal stents and angioplasty. But even with the newest generation of drug-eluting stents, we have to say that we are still not as close as coronary artery bypass surgery in terms of the risk of repeat revascularization. So I would conclude that revascularization of ischemic lesions is an important treatment asset and is associated with improved outcomes. There's no doubt that new generation drug-eluting stents have improved the safety and efficacy of PCI, both compared to bare metal stents and early generation drug-eluting stents. I think there's also no doubt that CABG is superior to PCI in complex multi-vessel disease. But there are some important insights, and that is left main disease indeed is a window of opportunity for percutaneous coronary intervention. And I also hope to have convinced you that the assessment of the risk of stroke particularly plays a role in very elderly patients. And I think diabetes, particularly in the setting of diffuse coronary artery disease, remains a shortcoming of both coronary artery bypass surgery and percutaneous coronary intervention, and needs some more improvement in both interventional strategies as well as medical treatment. Thank you very much for your attention.
Thank you very much, Stefan. As I told you before, it was going to be a very interesting lecture. I think we have the two chaps who have more information about what's coming in the next months all over Europe. And in fact, you all know yesterday the coach of the Barca soccer team died, the ex-coach. He was the coach after another one who was very well known, who is coaching now the Bayern Munich. And when he arrived, the first thing he said, I'm never going to fight with my predecessor because I am going to be always losing. And this is what happens here with Stefan. You cannot discount because he has always more data than you, and it's always very complicated. But after saying that, I just want to say a few things from the perspective of a surgeon. We are here interventional cardiologist and a surgeon. And you remember probably we were together many times at the PCR, and I remember one day they told me you have to interview for the TV PCR different people, professionals, to talk about the program Stand for Life. Most of the surgeons thought the idea of Stand for Life was a stent for the whole life, not just to get the patient alive after myocardial infarction, but that they found a new stent which is going to be the solution for everything. And a little bit, the surgeons, we have always the impression, and yesterday we were talking also with Chema about the hybrid procedures, that when you show the data in every meeting, you are always talking about 1 year, 2 years, 3 years, and if we are lucky and you have the freedom or the syntax, 5 years, but no longer. And then you claim, okay, saphenous vein, this is really bullshit. I mean, it's after 16 years, you have only 60% patency rate. What does it mean that? I say, well, what about you? Well, that's another issue. This is the past generation, and there is new stents coming every time. And I honestly think we should try to find a way to because we know a lot of things about selecting the patients today, something we didn't know 5 years ago. The syntax score was able to, as you have been able to show us, to select very well which patients could benefit of PCI, which one of surgery. We know a lot of things about many things, but still there is big questions. I mean, I am alone here. I'm the only surgeon. Yeah. But I have to tell you what some surgeons feel, for instance, about the Excel. And Marco maybe has, and you, I'm sure you have it, a good answer. Well, Excel trial was for left main. We were showing data about left main and syntax. The syntax for left main was not the first idea. It was not a randomization, it was just an observational study, and from the statistical point of view was something, well, we should not say anything about, but we do it. And then we say, okay, well, we are going to demonstrate that with the Excel trial. And then you have the Excel trial, and all suddenly they tell you, sorry, we have no more money, we cannot keep going. Well, I mean, as a surgeon, the first thing you may think is not going well, and the company is not going to put the money there. Because if you are sure it's going to be a success for the PCI, I mean, you call all the other companies, put the money there because this is going to be okay. So I don't know, you know, it's and I would like to have your opinion. Sure. I know you both are very honest guys, and I would like to be able to explain to people what you're feeling about.
Well, you know, I understand all the reservations, but really it's not that we want to upset the surgical community. It's really the innovation which drives this iteration.
And I am happy.
And interventional cardiology is a little bit like the IT industry. Apple also brings out every year a new device, even without randomized clinical trials. And it is just because it's a better device that it is accepted in the market. And I think we see this over and over again. You don't see it only in PCI, you also see it in the field of transcatheter aortic valve implantation. Until recently we talked about the problem of aortic regurgitation. Now we have devices which have abolished this problem. So the innovation obviously is so fast that every year there is something new which importantly improves the outcome, and that will not change. I would be somewhat provocative in terms of surgery. I think there's no doubt, and I have no hesitation to say this publicly, coronary artery bypass surgery is the standard of care in advanced coronary artery disease. It is clear-cut. And I also would say it doesn't change with more better devices, because we always will have limitations in very complex disease to reach lesions, to treat very complex calcified lesions. This will not change with more advanced technology. So even if we have better stents at hand, this will not change. Having said this, I also would say I think the entire benefit of coronary artery bypass surgery relates to the Lima graft, potentially other arterial grafts, whereas probably you could spare your time doing venous vein grafts, because I think we easily can do that in a percutaneous way. And therefore, probably kind of hybrid approaches are something to think about, where yes, you exploit the full advantage of coronary artery bypass surgery by providing arterial conduits and protecting long-term, very long-term, permanently, but at the same time give up on less effective therapies like vein grafts.
What about the left main?
The
Excel trial, yeah. What do you think about it?
Again, well, two things. I must say I'm disappointed, as you are, that this study takes shortcuts. And obviously it should be the way that if industry assumes the responsibility to conduct such a trial, that they also should do that to the end. I'm less concerned that there are problems with one arm versus the other. I think that nowadays companies are professional enough that they should not interfere that way, but it's certainly the credibility overall suffers. Now, having said this, I also would say now to the surgical community, one thing you need to acknowledge is that the entire evidence in favor of coronary artery bypass surgery, for example, as established by Syntax, has been provided by industry. And I think we have to be innovative in thinking about alternative modes of funding that we can do such trials independently, like, for example, the Freedom trial and so on. But I think we cannot only criticize industry. I think they have importantly contributed to available evidence.
Marcus, please.
Thank you. Marcus Flather from England. It's a wonderful discussion, and I was very interested to hear the surgical view. So we've been working with surgeons for many years on different trials and also pooling of studies. I think the diabetic story does need to have a clear guidance at the moment, because if there's confusion, then I think that we're not doing a good service for the evidence. So the evidence was generated, or hypothesis first, with Barry. We're talking in the 1990s. And then several trials, not specifically looking at that issue, but SOS and ARTS and so on, also were confirming in the subgroups that the diabetics were doing better with surgery. And then I think Freedom, and to a lesser extent Cardia, and the meta-analysis now is very clear that for diabetic patients with 3-vessel disease, complex disease, it is surgery that should be the first line guidance. And, I don't think we should confuse that. So your comment would be helpful on this point.
So I think there are two issues. One is, what is the available evidence right now? And there I'm completely with you. Diabetic patients with multi-vessel, and I'm saying 3-vessel disease, they fare better with coronary artery bypass surgery, and they fare better not just in terms of repeat revascularization, but prognosis, that is death and MI. I think that evidence is very robust, and there's no doubt about it. Nevertheless, I think one important thing is what is driving that mortality or ischemic benefit. Is it the diabetes itself, or is it the complexity of the underlying disease? That is diabetes just associated with more complex disease? And there, I think we don't have a clear-cut answer yet, and I think we need to analyze the data more carefully, whether it is really the diabetes in itself, or whether it is diabetes in the context of more complex coronary artery disease. And that's why I put up the discussion currently in terms of the Syntax score, which I think is not clear-cut in the sense that we can say it is in any diabetic, irrespective of disease complexity, or it is not. As a clinician, I would say that it is pretty clear to decide from a clinical point of view which diabetic patient will benefit from coronary artery bypass surgery, as most of the time they have more diffuse, more extensive coronary artery disease, and you clearly will favor coronary artery bypass surgery. Nevertheless, you do have these phenotypes of diabetic patients which do not like look like in typical diabetic patients with very focal disease. And there I think you need to more critically ask the question whether the evidence we have from Freedom and so really applies to also those subset of patients, and I cannot provide you the answer that it may be equally effective or not.
But Stefan, that's part of the problem, because the mechanism is something separate. So we can debate the mechanism for many hours, and of course it's important, but we must look at the evidence, and the evidence is very clear. So, if we have a diabetic with complex disease, let's not worry it's a diabetes or whatever. The evidence is clear that these patients, as a first recommendation, should be surgery.
Yes.
And if there's some contraindication, then we can consider an alternative treatment. The other issue is around stroke, and you pointed out that older people are getting stroke, but actually older people in the meta-analysis with Hlatke and ourselves, older people paradoxically are doing better with surgery. So I think there are some sort of myths around whether older people are going to do better with PCI. The evidence is not there. It is older people do better with surgery, diabetics do better with surgery. So, we do need to focus on the evidence.
So again, one point, and I think I made that clear, there is no doubt that in diabetic with 3-vessel disease, coronary artery bypass surgery is favored, and you will see that in the guideline. But this does not, you cannot put every patient into one box, and I think as a clinician you have the responsibility to critically ask also at the border zones, and there I'm in disagreement. There I would say the evidence is not clear-cut yet. I'm not saying it's favoring one or the other. I'm just saying it is a very interesting discussion we still need to lead. And you will not evade the problem that Freedom has not been carefully done in terms of the syntax score evaluation, and that deserves some discussion.
Thank you, Stefan, for your great presentation. Only one comment. I want to talk about a little bit briefly the transferability of data from trials to reality, because you're talking about Freedom, our syntax. I remember a paper in the European Heart Journal from the investigators of the Heart Survey, and they found that only 1/3 of patients, 1/3, could be eligible for a trial PCI versus CABG in the Heart Survey. And they analyzed the results, and they saw that in the eligible patients, there was a nice difference in favor of CABG, but in the non-eligible patients for trials, which accounted for the most, the difference was not relevant, because the patients, not eligible patients, have worse results with CABG. This is first thing, the population we are included in trials. In Freedom, most of the patients have a Euro score below 4. Mean age was 62 years. This is not the reality every day. And the second thing is the reproducibility of surgery, because the mortality of CABG in these trials was less than 1%, and I have the data from many countries and the national registry, and the mortality of CABG is 3 to 4% in most. Full arterial revascularization was 19% in syntax, and is 4% in US in general and in Europe. Then CABG is not the same in the trial than in reality. Patients are not the same. And looks like most of the patients we deal every day in practice are older, have comorbidities, have higher Euro scores. And maybe you transfer the mortality of these complex surgical procedures to the curves. You don't see any longer difference at 5, 10, or 15 years. That's the question. Yeah. How can we transfer the nice trials data to reality?
I think it's a very important question, because obviously the majority of patients do not fit into these clinical trials. Yet I would say, and I showed one slide showing the comparative effectiveness in the ASSURED registry, and I clearly would say coronary artery bypass surgery is superior in patients with advanced coronary artery disease. And that's also my clinical experience, that I think sometimes it's a little bit an artificial discussion we have. I think in the vast majority of patients, we exactly know this patient does not qualify for PCI, he should have coronary artery bypass surgery. That's the point I try to make on that slide. I think in 90% of patients, this is clear. And just to tell you an example, if you look at all kind of stent studies, the mean number of lesions treated is usually between 1.5 and 2. That is across all major interventional sites in Europe, in the US. If you look in syntax and in freedom, there was a mean of 5 lesions. This does not correspond to our clinical reality. So I think that gives you a little bit the answer that it is an artificial discussion. And that's what I also say is we can improve our technology as much as we can. Surgery will remain superior in those patients with very advanced disease. Now coming back to the very elderly and stroke, there I again take issue. I have a completely different view. And this is again a clinician view. And this is I'm doing a lot of TAVI procedures in octogenarians. For them, mortality is not the issue. It's not the question. They accept any kind of mortality if it's below 10 or 15%. But what their major issue is stroke. And they tell you repeatedly, I don't care if I die, but I do care if I have a stroke. And therefore, I think as a clinician, you need to take this into consideration. And I think there you just need to have a critical discussion with a surgeon. So nowadays it is common practice that you have an 82-year-old who has maybe advanced 3-vessel disease, where the evidence would say, yes, from our syntax score, we would favor coronary artery bypass surgery, but this patient was not routinely included in that trial. And there I think you need to have a discussion with the surgeon, and if technically it can be done by PCI, I would not go so far and say it's prohibitive. On the other hand, if the surgeon says he easily accepts that patient, you should favor coronary artery bypass surgery. So I think these are discussions you need to do on an individual basis, but I clearly would say in octogenarians you should entertain a discussion with the surgeon, but also with the patient.
Finally, the interaction in freedom with the US and non-US patients, because it's interesting, no? I think.
Well, yes. So, yes, obviously, I think it's a dangerous discussion. I think you obviously have this also with certain drugs which seem to work in non-US and then they don't work in the US. I would not like to go into discussions whether the procedure is better performed in one than the other. But it's interesting to note that there is the data, for example, for France, where they looked at the outcome of coronary artery bypass surgery and PCI, and there was absolutely no difference between the two. But I would not go into further interpretations on this issue.
The wine. Must be the wine.
A good one.
Well, thank you very much. I would love to be 2 hours discussing, but we have no more time. Thank you very much, Stefan. So, where is Marco? I think he has only two or 3 minutes.
Yeah. Here we have Marco Balgemili here. Yesterday he was participating in the sessions. As you know, he's from Italy, but he moved recently to Rotterdam, and he's also very well known for his research, his trials, and very active in European cardiology, interventional cardiology. Marco.
Well, thank you so much for the introduction and for the invitation, for the opportunity to be here again in a fantastic country, a city which I didn't know, with a lot of friends and colleagues. And as you would assume from the first slide, the Spanish root is quite strong at the Thorax Center as well. And I would like to start acknowledging Ramon Rodriguez, who is working with us in Rotterdam and who has been extremely instrumental for the preparation of the presentation. Pretty much following the style that Stefan has already used so far, I would like to look backwards to try to foresee the future, to look forwards. Balloon angioplasty is probably the reason why I'm here. It's proved the feasibility of the percutaneous treatment. However, vessel dissection resulting in abrupt closure and emergent bypass were really the issues in those days. Acute and chronic recoil were the enemies. Metallic stent came, and to some extent, at least this is my perception, they made our procedure predictable, and thanks to them, in a way, it became a real therapeutic option. Overall, restenosis rate was reduced, but the mechanism behind this was completely different, from chronic recoil to a new disease, which is intima hyperplasia. That's why first generation DS has been so greatly welcome, because they indeed have reduced target vessel revascularization need by as much as 60–70%. However, they were not clearly perfect devices. Very late stent thrombosis was in the range of 4 to 5 times higher as compared to bare metal stent. On an absolute basis, still quietly rare, but on a relative basis, the difference is quite impressive. And bare metal and DES has probably created what we can now call DAPT dependency, the perception that once you have one of these devices on board, you can never get rid of dual antiplatelet therapy, otherwise something horrible will happen. And finally, the new generation DES, which has been greatly summarized by Stefan before me. They, I'm not so sure we can speak about the class effect, in a way preserved, or maybe they even increased efficacy, but perhaps more importantly, they improve safety. And we have some important early signals suggesting that actually the safety of this device may be much better, even as compared to our bare metal stent. Importantly, they seem to be more DAP3 friendly in a way, and perhaps, and I really hope so, we will be soon able to show that DAPT should not be for stent protection, but rather for patient's protection. And so DAPT should be depending on patient type, not on stent type. But we have some important issues I would like to a little bit elaborate on. And the first one to me is really long-term care. In a way, we have already seen the data, or at least some of the data, suggesting that there may be some time-dependent differential effect of one treatment versus the other. This is the SINTA score at 5 years follow-up, published last year in The Lancet. And here you see death, MI, and stroke, the so-called safety endpoint. Nothing is happening in the first 2 years, actually, but afterwards, you clearly see these two curves start diverging one from the other. And as we have already seen, this is largely driven by MI rate, which is as much as 3-fold higher in a PCI patient as compared to CABG. But also looking at the numbers, it's quite disturbing to see that the mortality rate is also not favoring PCI as compared to CABG. Completely different scenario, also completely different methodological approach. This is a single center, non-randomized observation in 2,000 and over patients who underwent primary PCI with a very long-term follow-up, up to 16 years. 600 patients undergoing balloon angioplasty, and then 1,000 plus patients undergoing stenting, either bare metal stent or first generation DES. And what you see here, that there is perhaps an advantage on stenting over balloon angioplasty early on cardiac mortality. And then from the second year onwards, these two curves are pretty much superimposable, with anything, perhaps some slightly divergence of the stent group at very long-term follow-up. If you look at stent or lesion thrombosis rate, you see a pretty much consistent pattern early on, but later you have a significant p-value disfavoring stent as compared to balloon angioplasty. And if you look at target vessel-related myocardial infarction, this difference is becoming even more impressive. And if you believe that these late events are only driven by first-generation DES, you are wrong. Of course, they do contribute, as you would have expected, but even bare metal stent seems to fare slightly worse than bare metal stent at very long run, perhaps suggesting that caging the vessel is not really the way to go. And finally, we have to be honest, the dream of preventive medicine is still remaining a dream today. I think we have got quite good in treating acute MI, whatever type of STEMI, non-STEMI, but preventing it is a completely different story. So the critical question is whether are rigid permanent scaffolds the way of the past? And of course, we have no answer today. But at least we have a number of reasons, which are perhaps summarized here, suggesting that these could be a major breakthrough technology for us in the future. And the stent type for which we know most is this one, is a polymeric eluting PLA everolimus eluting stent. And actually this stent, this technology, the PLA, the polylactic acid, is quite interesting because in a dry environment it has mechanical properties which are very similar to mechanic stent. But once put in water, it undergoes hydrolysis of the ester bond, and the polymer gets to be degraded. First, the molecular weight goes down, then lactic acid is released, finally leading to mass loss, and at the end of the day, the whole polymer gets into the Krebs cycle, and it's transformed into carbon dioxide and water. And step by step, in a time-dependent manner, the stent simply vanishes away, disappears. And the beauty is that with intravascular imaging modality, perhaps better off with OCT than anything else, we can really monitor over time what's going on with this scaffold. And the beauty is also that at least we don't have the shadowing effect that metallic stents are supposed to have, and therefore it's quite nice to follow their appearance over time. Now, a few introductory notes with respect to nomenclature. Absorption, degradable, they should not be used because actually they do not make the point that these scaffolds, they do not just disappear from the site of implantation, they completely disappear from the body. So the UPAC classification, which was recently put forward, is really suggesting to use bioresorbable terminology, which is really describing what's going on with this scaffold type. Not just the stent disappears from the site of implantation, the stent gets completely eliminated over time. And it's quite interesting to elaborate on the fact that every living system is indeed characterized by a self-healing feature. It is the stress restoration concept. And so bioresorbable scaffolds are supposed to provide a sort of a stress shielding opportunity when it's critically needed during the acute phase of revascularization, perhaps subacute phase of revascularization, but finally allowing for a self-repair mechanism, which is perhaps, that's what we hope at least, the only way to get a real restitution ad integrum. And here you have a schematic overview of what's going on with all of this technology. After implantation, once the technology is being exposed to water, hydrolysis starts to occur and you have a decrease in molecular weight, which is not leading to a loss of mechanical support until actually molecular weight is 50% what it was originally supposed to be. And then all of a sudden you have a loss of integrity of the stent, and afterwards a mass loss starts to happen when this tie change from the crystalline and the semi-crystalline polymer starts to happen. And very importantly, when the mass loss is occurring, the stent, the vessel is not caged anymore, and late lumen enlargement can occur, and actually it has been demonstrated to occur in vivo in our patient. Of course, the timing of degradation is incredibly important. That's what we have learned in the first years. This is really a very important observation which has been reported with the first generation Absorb, the so-called BVS 1.0. And if you look at the late loss, in the way we have always been measuring late loss after balloon angioplasty or after stent, actually the performance of this device was pretty much in between what BMS and what a good second generation DS can provide you with the overall late loss of 0.43. But actually, this is not driven by neo-intima hyperplasia. If you look at the volume of neo-intima hyperplasia, that's very limited. This late loss was largely driven by a reduction of the scaffolded area. So the stent starts to be degraded and the scaffold area gets shrinked over time. And that's why you have a sort of lumen reduction, nothing to do with lead loss. And so based on this observation, there has been a second iteration of this first technology, which has resulted in so-called revision 1.1, a different way of processing the polymer together with a different stent geometry, as you clearly can see here, and the combination of these two elements has actually resulted in more radial strength, longer duration of support. The company claimed same total absorption time. I have some doubt this is true. Storage at room temperature is now possible, which is of course a great advantage for this device to be used in the clinical setting, and importantly, no change in strut thickness, which does remain in the range of 150, 160 micron. And actually, this iteration has really resulted in a much improved patency rate. This is the follow-up of the so-called 1.1 generation, and what you see at OCT, no decrease of scaffold area at 6 months whatsoever. At IVUS, there's been some decrease in the scaffold area, which, however, favorably compares with what has been reported before. It was 12% in cohort A in the so-called 1.0 technology, and in the 1.1 technology, this went down to 5.4, and late loss pretty much came down in the range of newer generation DS. If we want to have a longer then if you want to have a 3-year follow-up of the absorb, this is data has been recently published in multiple publications, so let me quickly go through them. Here you see very interesting technology, which is the hyper-echogenicity over time, and what you see here is the technology 1.0, the absorb 1.0, and you see here that from the moment of implantation to 6 months, you really already have a 50% reduction of this parameter. In the second generation, the 1.1 iteration, you have to wait as much as 33 months to get the same level of reduction, this 50%. So based on this information, we could speculate that actually the complete resorption time has been increased by 30 months from the first to the second generation device. But the very interesting observation is really what's going on with respect to lumen and plaque over time. That's why intravascular imaging is so critically important to understand the value, if any, of course, of this new technology. This is serial OCT assessment, which actually confirmed what already the Agudos was suggesting before, namely that the fact that you are freeing the vessel from being caged over time, the vessel can get bigger. And this late lumen enlargement is able to compensate, in some analysis even overcompensate, the continuous growth of intima hyperplasia over time. So the question is what's going on beyond 3 years follow-up, and unfortunately we do not have the answer yet with the second generation technology because follow-up is still going on. But we do have very late data with respect to the first generation technology, again suggesting here it's a very limited data set in patients who underwent multi-slide CT at 18 months and 5 years down the road, and what you see here is a slight decrease in plaque area, which is leading to a decrease in vessel area, and finally the lumen get preserved over time. Exactly the same findings in this matched analysis using a grayscale as well as VH technology, which is showing in a very limited number of patients, so we have to be very cautious in over-interpreting these numbers, that there is indeed an increase in the lumen area over time. There is a decrease in the plaque area over time, which is finally justifying the decrease in the overall vessel area. And you see that the lumen gets bigger and the plaque behind the scaffold strut gets smaller and smaller. This has been confirmed, and perhaps even more so at OCT, which is actually leading to a new terminology. And you may guess from whom this terminology is coming from. Patrick Serrais, who is the father of the technology, created a new terminology, the final Gödel tube, really to emphasize the fact that OCT, there is homogeneous light reflectivity on over time. And this intima hyperplasia can really cap the underlying plaque. It provides a sort of late lumen enlargement, which seems to be really the feature of this bioresorbable technology, which is something we don't see and we cannot see when stents are there for life, to use an expression that we have used before. You can restore vasomotion, and of course the dream, which has still to come true, unfortunately, is to hypothesize that this can perhaps lead to a sort of plaque passivation over time. Do we have randomized data? And the answer is absolutely not at the moment. We only have a single arm prospective observational data. So it's very difficult for the moment to understand the value, if anything, the added value of the technology as compared to what is already in use. And so the best that we can do is to try to match this single center registry to patients having perhaps similar feature characteristic coming from the SPIRIT 1 and 2 studies. And what you see here that perhaps during the restoration phase, the event rate is pretty much similar, or perhaps, if anything, slightly higher in patients having received this new technology. But of course, the hope, which has to be confirmed, is that later on during the resorption phase, this new technology can have an edge. So what's going on and what are we going to see in the near future? Here you have an overview of all absorb studies which are driven by Abbott Vascular in terms of sponsorship. And for the time being, we have 1,137 patients who have already been recruited in randomized or non-randomized investigation. But the truth is that this number will get at least 10 times bigger in just 12 months from now. And of course, this is only the beginning of a new era. And here you see an incomplete list of what's going on with respect to investigator-driven studies. The first study I would like to point out is the AIDA study, which is running in Amsterdam. That's an all-comer study comparing EES versus BVS. And then we have the Trophy2 study, which is led by Stefan Windecker, which is focusing on patients with STEMI who are being randomly allocated to either ES or BVS. And finally, very interesting, the Prospect2 Absorb study, in which the dream of plaque passivation with this new technology is being explored. And it's clear that the BRS technology has only started, perhaps not based on what we have discussed so far, but based on the notion that if you look at the number of companies which are really investing in this market is quite impressive. We have perhaps more than 20 startup companies or not startup companies working on this technology. 2 of them have already received the CE mark. We extensively discussed about the Absorb, the BVS study, but there is another technology coming from the United States which already received the CE mark. And you see that 7 other companies are in the clinical phase and 8 in the preclinical phase. With respect to the material that is currently being tested, every possibility seems to be possible here. 7 are based on the PLA-PDLA copolymer, very similar to what we have seen so far with BVS, but there are 3 companies investing on magnesium, 4 companies investing on other copolymers interaction, and finally 1 with iron and 5 with unknown material. And now we are transitioning from patient to single stent registries actually to the market. This is a sort of investor provision over time, and they use the JP Morgan model. They use what they have seen occurring in the past with the first generation DES, the Cypher stent. Now we are pretty much here with respect to market share, much less than 10%, and they provision. The future provision is that in 3 years from now, the penetration of this technology is going to be as much as greater than 40%. We will see whether this forecast will turn into something real. But I would like to go back to our everyday clinical practice, and I would like to close by presenting with you a case which is probably making the point about the use, or perhaps even more the misuse of BVS in current practice. This is an acute MI patient who got proximal LAD occluded. The interventional cardiologist reopened the vessel with pre-dilatation, and here you see the results. And then, without thinking too much, probably, a scaffold has been implanted in what it was thought to be LAD. But if you, of course, look at the final angio imaging, it's quite clear that LAD was left occluded, and the scaffold was placed from proximal LAD into the first diagonal. The patient did not like this procedure, and indeed, the patient came back to the thorax center 1 week afterward to see whether we could fix this issue. And I can reassure you that it has been a hell to do it. It was quite difficult to get a wire across this very bulky scaffold technology, but even more interestingly was to do OCT from a diagonal to LAD to see how malapposed the scaffold was. And when you are in a clinical condition here, you have such high degree of malapposition, that's a big problem, because this stent cannot be expanded any further. This is not a metallic stent. And so the only way you have to fix this issue is to completely destroy the stent in itself, and that's actually what has happened in pre-dilating the LAD, which was occluded, and here you see the 3D reconstruction of OCT. You have some fragment of the scaffold, but of course there are only byproducts really floating in the lumen. And at the end of the day, the only way to fix this problem was to put a metallic stent where the scaffold was probably supposed to be placed in the original procedure. So BVS ready for prime time? Well, I think the answer is yes, but I'm really closing with this case to make the point that we should never forget this is no metallic stent. This is a fantastic technology, but still plastic, so handle it with care. Thank you so much for your attention.
Thank you. Thank you, Marco. This was an excellent presentation, also looking at the shortcomings. Now, you mentioned the preventive aspect, and obviously it would be appealing to have an effective treatment for future important lesions which we're not currently treating. But I think one important caveat is, how do we identify these vulnerable plaques? Do you have any thoughts on that?
Yeah, so this is a matter of research which has been going on for many years, and unfortunately the answer is that we have no clue. We have multiple imaging modalities, we have perhaps multiple circulating markers, but at the end of the day, none of them is really able to let us know which plaque will finally undergo a rupture and subsequently NMI. What has been reported in the prospect study is the amount of plaque burden is probably the most important one, more than the plaque characteristic in itself, or at least the plaque characteristic which can be detected with available intravascular imaging modalities. And actually leveraging on this observation, the ABSORB2 BVS study, we really look into these high plaque volume burden patients who are perhaps not critically significant at the moment of treatment, but can become such over time. And indeed, the principal aim, the principal goal of that study is to try to reestablish late lumen enlargement in this setting as well. My personal feeling is that this technology is too premature, too pioneeristic to go in that direction. And with this available technology, we will never justify whatever early event rate to try to reduce late event rate, because actually the price we will let our patient pay early on is probably too high. That is my personal feeling.
In terms of the biodegradation process, we have the polymeric devices, but we also have the magnesium-based devices. Do you think there are important differences between those to favor one over the other?
Well, I think it's an excellent question, because having used and using this plastic technology in everyday clinical practice, I have to say that this is a completely different procedure, and you have the feeling that you have to work more and perhaps expose the patient to a higher ischemic risk early on. If the concept of bioresorption will be reproduced in the context of a stent which early on will behave exactly as a metallic stent, I think in terms of principle, this could have a major edge over plastic technologies. That's what I think. This technology is currently being investigated in a film study, and so this technology is currently coming to clinical practice as well.
Just to come back on the last example you showed, you think this technology will be an angiography-based only implantation technique, or do we have to be here more stringent?
That's an excellent question, and I am not a huge fan of intravascular imaging. I normally try to stick my procedure as easy as I can, but using this technology, you really have the feeling that you cannot only rely on angio, because the risk of undersizing or perhaps oversizing the scaffold is big, and once you've done that mistake, you cannot go back, as I was trying to show. So it's completely different technology, and probably not even IVUS. Perhaps high resolution IVUS on OCT is the way to go for the future.
Hey, Marco, great presentation. All of us, all interventionalists, have the BBS in the shelf for 1 year or so, and you see that it's very heterogeneous, the use of the device. No? In some centers they are using 30% penetration, in other centers 10%. We, in our institution, is there, but the penetration is still around 10% or something like that. Very practical question, what's in your idea of the patient profile of the lesion subset that gets more benefit from this technology? Meaningful benefit in the long term?
Well, based on the data that we have seen so far, and based on some early clinical experience, I would really target patients with extremely low CAD complexity, perhaps one single focal lesion, very little amount of calcium, in which probably you can get a fantastic result after balloon angioplasty. That would be probably the ideal candidate. If you start using the technology in a complicated CAD patient, I think you will expose the patient and the technology to a much higher risk than what it should be.
Please, Marcos.
Sorry, one brief question. Marcos, fantastic technology, and as Stefan was alluding, the field is very technology driven. So one contrast between Europe and the US is that you know, in Europe you can get a registration for a device based on very limited data, but the device is basically still experimental. Whereas in the US you have to get, you know, any device has to be FDA regulated and only approved after, you know, the evidence is clear. So do you think the European approach is working? I mean, we have all these experimental, unproven devices and, you know, people are using them, but is that the safe or the correct approach, or is it better to, you know, not issue a CE mark, get proper evidence, and then allow it to be used in clinical practice?
Well, Marcus, that's a great point, and it's very difficult to answer that. In a way, of course, the more you study a device, whatever type of device is, the better you have understanding about the safety and the efficacy of the device. And so these would more speak for FDA approach more than the EMEA approach, because of course they are requesting much bigger study and much greater evidence before anything is getting approved. On the other side, the counter argumentation is that if you look at what we have seen after first generation DS, none FDA nor EMEA have disclosed early on what we have learned to be the case, namely this very late risk of adverse event years after implantation. So the question is, what sort of study would then need to be in place before you can really tease out the real value of the device? And my answer is that I have a strong feeling that you need to test this device in a non-randomized manner, in a clinical scenario manner, before you really understand the value of the technology. I think the blame should be more on us than probably the regulatory agents, because once a device is being approved, you should use the device according to its approval indication, and that's something we almost never follow.
Okay, we're going to close this interventional session because we are running out of time. We appreciate and we thank Marco and Stefan. They have to leave because he has the flight soon. And thank you for your attention this early morning.